Good morning. I'm Jessica Lovell. I'm at home today taking the advice that we always give to stay off the roads when they are snowy and icy. But the good news is that our COVID count is down from last week. We have 16 inpatients right now with currently 3 patients in the ICU. Now, we had promised to bring you a program where we discussed head and neck cancer. And while we work to reschedule that program, please enjoy this pre-recorded episode talking about a gift from a son to his mother. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. When Anne Holzbeierlein learned that she had leukemia, she had a great ally in her corner in more ways than one, and we'll tell you why here in just a bit. Her son, Jeff, is an accomplished oncologist here at the University of Kansas Health System, but even he ended up getting some guidance from his colleagues. And today we are learning how Anne got the life-saving treatment that she needed, even if her bone marrow donor wasn't 100% match. And Anne is joining us now here in studio alongside her son, Jeff, sitting across there. Of course, we call him Dr. Holzbeierlein around here. He is a urologic oncologist and the newly appointed physician-in-chief at the University of Kansas Cancer Center. How are you both doing? Mom, son, good?
Great.
Very good.
Proud mom?
Yeah.
Yeah, proud mom. Okay, you can have that moment there. Dr. McGurk, always great to have him with us. He is Director of Hematologic Malignancies and Cellular Therapeutics at the Cancer Center as well. How are you?
I'm doing well. Thank you, Jess.
Good.
Thank you for having me.
Yeah, good to have you. It's nice to have son and mom and patient and doctor
You bet.
all sitting here at the same table. So, Anne, let's like just jump into your story. So you were diagnosed with acute leukemia, AML, back in 2013. Is that correct?
That's correct.
So tell us just what symptoms you were feeling. Were you relatively healthy up until that diagnosis?
I really never get sick or anything, but I was extremely tired. I kept working and everything, but one day I was walking across campus. I worked at a university, and I couldn't walk all the way back from a meeting without sitting several times and stopping. So I went to the health center on campus. They did some blood work. I thought maybe I was anemic or had mono. And at 10:30 that night, the doctor called and said, you need to go to the emergency room. And that was the first I learned what I had.
So you actually heard leukemia and
Not from
possible
her, but
cancer?
Not from her, but as I got to the emergency room,
So
they
when
immediately said that.
We've asked people that a lot. You know, you hear the C word. You know, what are you feeling in that exact moment?
To be honest, I was too sick to have any feelings. I really don't remember like the first couple of days after I was diagnosed. They immediately started treatment, but I don't remember anything from those days.
And so smart to go get it checked out, because we've talked about this. I'm tired all the time, Dr. McGurk. I mean, you know, and so it's so hard to miss those signs when you just think life has taken over and you're tired, but you knew something was wrong when you couldn't make that walk.
Correct.
So you at some point call your son, Dr. Holzbeierlein, Jeff. What was it like when your mom told you, a doctor, what was going on with her?
Yeah, well, sadly, I'm more of a solid tumor person and not a liquid tumor person, and I really didn't have a lot of knowledge about leukemia at that point in time. So I reached out to one of my colleagues on the medical oncology side, then connect me with Dr. McGurk, and he was able to educate me in terms of sort of the seriousness and the acuity of the diagnosis. I really kind of had the sort of more childhood leukemia bent, whereas, oh, you get chemo and you're cured and not a big deal. That was sort of my initial reaction.
Right, and you're a physician, and one of your beloved family members is sick, and you want to try to fix it, and you realize, thank goodness you work here and you work with this guy. He's the guy you pick up and call right away, right, to get that information.
Absolutely.
So you went on this hunt for more information, but what were the conversations back and forth? You live in Oklahoma City, you live here, and you're talking back and forth about a plan and health care. How was that just on a personal family level?
Yeah, so again, Dr. McGurk was guiding me during this thing. My mom was initially at a private hospital, and we both felt that it was important that she get transferred to the University of Oklahoma Medical Center, where they had a little bit more expertise in treating AML. And so Dr. McGurk had recommended that, and he helped reach out to one of their bone marrow transplant leaders there, and really helped negotiate the transfer so that my mom was able to get transferred to OU.
So, Dr. McGurk, what is AML for those who are listening?
Acute myelogenous leukemia, it's the most common form of acute leukemia in adults. and it's a cancer of bone marrow stem cells. Bone marrow stem cells, when they're behaving and behaving normally, generate all of our blood elements. So our red blood cells that carry oxygen to our tissues, and platelets that help us stop bleeding when we cut ourselves, and the white blood cells, of which there are many different types that make up our immune system. All of that comes from the bone marrow. Bone marrow stem cells, like other cells in the body, all other cells in the body, are susceptible to developing genetic abnormalities that can give rise to a disease like acute myelogenous leukemia. And for adults, a stem cell transplant after chemotherapy is the most powerful way of curing this disease, and it is a curable disease in patients if we can get them to transplant.
So Anne, you started on chemo then immediately, and how long were you on that treatment plan?
About 35 days.
Okay, and then you come along, when did you two connect? Because then you were able to present her with an interesting clinical trial.
Yes, Ms. Holzbeierlein had received chemotherapy at the university in Oklahoma, as Jeff described, and that's pretty intensive chemotherapy, and she can tell you better than I can because she's walked in those shoes just how intensive it is. And when she came up to Kansas City, she came up to talk about a possible stem cell transplant. Now, most patients who might benefit from a stem cell transplant don't have the optimal donor, a brother or sister who happens to be a perfect match for them. And so for the majority of people who don't have that perfect match, we looked at a worldwide registry of unrelated donors, about 40 million people willing to donate stem cells. But there too, if you're Caucasian, Western European descent, your chance of finding a match is about 75%. It's not 100%. So not everybody's going to have a match. And so what do we do for those folks who don't have a match in the family or in the worldwide registry? And we've been exploring for a number of years alternative strategies using family members like Jeff who are not a full match. They're a half match. He received half of his immune system and the cells and the genes that code for that from his father and half from his mother, so we knew he had to be a half match. If he weren't, then there would be a different conversation. But he certainly was. Yeah, that's correct.
So that's what we're talking about today, because Dr. Holzbeierlein ended up being a haplo match for his mother. How did this all come together? As far as you go, Dr. Holzbeierlein, you get tested to make sure that he's a match for his mom, and then what's the next step?
Well, when she first came to our clinic, I met her that day, and we discussed with her a clinical trial looking at two different strategies to potentially allow access to transplant for patients who otherwise wouldn't have access because they didn't have a match donor. One is umbilical cord blood stem cells. They can be life-saving in patients in need of a transplant. The other is a mismatched family member like Dr. Holzbeierlein. And we didn't know which is better or either better or both equal. And so we conducted, and we were one of the lead enrolling sites in the United States, a prospective randomized trial where patients were assigned to either umbilical cord blood transplant or a mismatched family donor transplant like that from Dr. Holzbeierlein. And she randomized to that the haploidentical arm of that important clinical trial. So we didn't know the answer at that time. We do know the answer today. When she came to see us, I sized her up and did an exam, and I infamously said, geez, you look kind of frail for the clinical trial. I'm not quite sure. And she straightened up, sat up in her seat, and basically, more politely, said, how dare you tell me that I'm frail? She said, well, let's move it forward. And we moved it forward.
Don't you tell me that I can't handle this.
Right.
Exactly. Okay, so tell us more about that. So, because people, get presented with trials, and oftentimes it's kind of an act of bravery to step forward and to be a part of advancing medicine. And when Dr. McGurk brought that option to you, what were your thoughts? Other than sitting up straight and saying, bring it on.
Well, I was lucky because I probably had the best informed advocate for me. So most anything that was presented to me, I talked it over with Jeff, and he would kind of guide me. I laugh when I was in Oklahoma City. My doctors probably hated me because they put a program on my phone, and every day I scanned to Dr. McGurk and Jeff all my blood results, so they were up to date. So the doctors there are probably going that. But I think Dr. McGurk has a team that I met with, and they told me a lot about the different steps, what would happen as I was making this decision. And to be totally honest, I didn't have a lot of choices. But they also presented, if I didn't do it, what that looked like. So I was well informed all along the way.
Dr. McGurk, is it risky for someone like Anne, bone marrow transplants? Tell us about that.
There are significant risks associated with bone marrow transplantation and umbilical cord blood transplant as well. We destroy a patient's immune system with radiation and chemotherapy in combination oftentimes. That in and of itself exacts some toll on the patient, causes toxicities, can cause organ toxicities, and we'll lose a small percentage, but real percentage of patients just to those toxicities. We destroy their immune system, and then we take someone else's immune system, which comes in the form of their stem cells from their bone marrow, and transplant it into our patient. And that immune system may recognize our patient as foreign, the opposite of rejection, cause a problem called graft-versus-host disease. We'll lose some people to that. It's a common problem after transplant as well, especially after a mismatched transplant from a cord blood or a mismatched family donor, at least historically. And then patients are at great risk for infection for many months after transplant. And so lots of do's and don'ts to keep them out of harm's way. Things like COVID, potential disaster, and even simple cold viruses in the community. But we're covered with trillion bacteria, fungi, viruses, all of us. And they don't cause us trouble when our immune system's intact. But when you compromise that immune system, they can become real trouble. So it's a complex process. But when you look at the alternative for patients with adult patients with acute myelogenous leukemia, with a few exceptions that have so-called good risk disease. Most patients have intermediate or high risk disease, and those patients are almost incurable without a transplant. That will change in the years to come, but that's where we still are today. And so when you look at the risk of transplant and a 20-25% chance that we're going to lose them from what our team did to them in the first year after transplant versus virtually 100% that we're going to lose them to the leukemia, then it becomes somewhat more acceptable to say, okay, those are significant risks, but the risks are absolutely well worth the potential benefit of being cured of this disease.
All right, Dr. H, so this is the woman who gave you life, and now it's your chance to repay her. So tell us what went on in your mind. You're trying to just kind of take this all in and make the right decision for your family. Was there any hesitation?
No, I mean, it should be mentioned, as Dr. McGurk mentioned, the outcome without a transplant was very poor, right. And she was not offered a transplant at OU, so there really wasn't an option there. She met with both palliative care here, as well as with Dr. McGurk's team, and I remember we got on the elevator after she met with Dr. McGurk's team, and after the discussion about a clinical trial, and we both said, this makes total sense to us. I think both of us, my mom's been in education her whole life. Obviously, I'm a huge advocate of clinical trials and the power of clinical trials. So for us, that made total sense.
All right, so you were on the other side of the coin. You were the patient, you were the donor. What was that process like for you? Yeah,
so many people have the idea that when you harvest stem cells that you can just harvest that from having a blood draw. Mine was a little bit different. I had to actually have a bone marrow aspirate from my hips, which required a general anesthetic. But I operated that morning, had my procedure, and I was back to work the next day. So.
Of course you were. Of course you were, right?
Fine.
So how was your recovery, Anne?
Well, actually, that part of it was fairly painless for me. It was intravenous, which I was surprised, and so it was very simple to have. Then I was in the hospital for about 3 more weeks. I think they did it on the 6th, and I went back to Jeff's house on the 28th. And then the biggest challenge for me, I had to be within 30 minutes of the hospital for 100 days. So Jeff and his wife graciously let us stay at their house with their 4 children and 2 dogs.
Yeah. Okay, that's a lot of people, Anne. Okay, all right. I hope he was on his best behavior. Were you feeling like the patient or the doctor? What was it like, that relationship when you're the patient as the donor, but you're the doctor of the family? How was it like for you as far as just how you felt day in and day out? Yeah, most of the time I would say, again, without a ton of knowledge about the hematologic malignancies, I really let Dr. McGurk's team and as my mom mentioned, really the one thing that doesn't probably get enough credit is how incredible the team that's been assembled in the HMCT division is. They just do from the very beginning to the very end, the amount of support
and education of patients and family members is incredible.
Well, and that's the great thing about being at our place is everybody is so specified. So when something like this happens, you get to take a back seat and let the expert come to the forefront. And I mean, you've been there for other doctors when they've come to you. I mean, you're the one, you don't have to have all the answers under this roof. So I love that. What's it like seeing Anne sitting here? And is she cancer-free?
She's cancer-free, and it is statistically extremely unlikely she'll ever deal with that cancer again this far out from transplant.
Really?
And, absolutely. Most patients with acute leukemia who are going to relapse after a transplant, and about 50% do after this type of transplant using a mismatched family member. Most are going to do it in the first year. A few people in the second year, and beyond that, it's rare for someone to relapse. Now, I mentioned that 50% of patients relapse, and so as Dr. Holzbeierlein pointed out, that's not acceptable. That 50% who don't relapse didn't have any other options, and we would have predicted that we would lose almost all of those patients historically. And so seeing her today is an absolute miracle. It's a miracle of science and her determination and perseverance through very difficult and trying circumstances, certainly including our complex transplant. So when I see our patients after transplant like this, I just think it's awe-inspiring.
You know, it's that
I still do. It hasn't changed throughout my whole career.
It's like every patient, it's that feeling.
Right.
It never gets old. And just like you call it the gee whiz science. Where
Absolutely.
you just get to, a doctor like you gets to sit back in awe and watch this come together and watch people like Anne live a
And I wanted to make the point just too that Dr. Holzbeierlein, so that 50% who are relapsing still, we've come halfway. We still have halfway to go. And we do that in the context of clinical trials. So now we have a clinical trial that's very exciting where we take cells from the donor before we do the transplant called T cells, and we modify them in the laboratory. We do the transplant, and then we infuse those cells to prevent relapse. And I just presented those data in a meeting in Paris a couple weeks ago, and in that trial, we've treated only 8 patients so far. But out of those 8 patients, we would have expected half of them to have relapsed by now. No one's relapsed so far.
Are we talking about CRISPR?
That's not CRISPR. That was another presentation at the same meeting.
Gotcha.
Yes.
Okay. So, so this just really talks about the importance of trials. I mean, we can't not talk enough about that. You presenting them, but then people like Anne participating in them.
That's right.
So how do we, I just want to talk to the table a little bit about the importance of trials because you're involved in them, Dr. Holzbeierlein as well. Just talk to us about that and the how we reach more people and make people feel good and comfortable about being a part of advancing medicine.
Yeah, I think part of it is education and awareness, right? Many people, first of all, may not be aware that they're eligible for a clinical trial. So it starts with educating our patients about clinical trials. I think a lot of people also, particularly sometimes in underserved communities, have a lot of bad baggage when it comes to clinical trials. And so it's really, I think, incumbent upon us to, again, do a lot of social awareness and education that clinical trials are different. The way that things are run these days are often very different. Many people oftentimes have this sort of view that you're getting a sugar pill or you're getting treatment, and actually the vast majority of clinical trials no longer require a placebo. They are usually a standard of care arm plus an experimental arm. So active treatment versus something that's novel.
Are trials always the last line of defense, or can they?
Oh, absolutely
Are they
not.
Becoming the first line of defense
Yes.
for many people?
Very much so.
Talk to us about that.
So for many patients, as we've learned more about how what makes cancers tick, and what are their Achilles heel, what makes the immune system function and what goes wrong when it doesn't function. Because our immune system is not just there to fight infection, it also controls abnormally behaving cells, like cells that have the potential to turn into cancers. We've leveraged that knowledge. We stand on the shoulders of men and women in laboratories throughout the world community who have unfolded and revealed those stories and how things work, and that allows us then to say, if that's true, then we can manipulate that system and prevent this from ever happening. So clinical trials go from the prevention of cancer, even before someone has cancer, all the way through the most extreme circumstance, developing a very aggressive, potentially lethal cancer such as acute myelogenous leukemia. And it's only how we got to the place that we are today that we arrived here through one clinical trial after another as years go by, and we keep building on these. So haploidentical transplant, we move the ball forward with that clinical trial that I mentioned earlier that Mrs. Holzbeierlein participated in. 50%, not good enough. More clinical trials that, okay, that's our platform for the next clinical trial, and then the next clinical trial. And so our goal is to have a clinical trial for everyone who's diagnosed with a cancer who comes through our door. We're not at that place yet. Not sure that any institution in the nation is, but for many of our patients, we have a broad array of clinical trials, particularly at a National Cancer Institute designated comprehensive cancer center such as ours.
Anne, you are living, breathing proof of the benefits of clinical trials. What message do you have to people who are watching, who may have an opportunity to step into a trial, learn more about them, or maybe in the future they could be a part of science?
I mean, obviously, I'm a big supporter of them. Like I said, one of the things I thought was the best about here is the team that I had, and it went from medical people. I met with a dietitian. I met with somebody about finance. So I think from that aspect, I didn't have any concerns or fears going into it.
You weren't left hanging
No.
to try to figure it out on your own. What are you most looking forward to doing? I know you have traveled up here to be at one of your granddaughter's graduations. I would imagine milestones like that you're looking forward to.
Well, I'm hoping maybe one of my grandchildren will get married and I will have a great-grandchild one day.
Yes.
But I'm going to Paris in September, so we're going to visit a little bit more about that. I travel a lot, and I recently retired from a large university, so I'm just enjoying pickleball, mahjong, anything I want to do.
So you're just getting back to life. So that's what we wanted to have you both on. And I want to take a little look back into the Holzbeierlein family photo album, if we may, because that's always fun. Okay, first just tell us what this is. Dr. H, you on the left in your suspenders. Were you graduating from one of your many?
That's,
okay, that was just
graduating from Vanderbilt University.
Okay.
My grandmother's in the middle and my dad's in the back, and then of course my mom's right next to me.
Of course. Okay, now what do we got?
That's graduation from high school.
Oh gosh, okay, you're like a baby. That's a baby.
Yeah, I actually had a childhood.
You did, okay.
And had to grow up, and yeah, so that's my graduation.
And you
from
grew up in
high school.
Oklahoma, right?
I did. I grew up in Edmond, Oklahoma.
Yes, okay. Oh, we don't get to see the mullet? No mullet photos. Did you take those out?
I think that last one sort of had it.
Had it. It was hiding back there. You sent those on my phone. I was like, oh, dang, he's got a mullet. I love it.
It was the 80s.
You were rocking it, though. You did it well. You did it really, really well. So I appreciate you being here and sharing your story. It's just always cool to see, again, the big flow of how this all comes together. So thank you for that. Dr. Holzbeierlein, I'm going to start on that end of the table. What do you want the takeaway from our conversation to be today?
You know, I think we've talked a lot about clinical trials, but I actually gave a talk and sort of presented the case at a national conference, and then the story obviously evolved to the subject being my mom. And, you know, I think it's oftentimes easy for us to sort of talk the talk about a clinical trial, but this is actually walking the walk. I not only talk about clinical trials and the importance of it, but this shows the belief I have in participation in clinical trials.
And what's the takeaway from your story?
I think having a medical team that you have full trust in is really important. And again, clinical trials. Both sides of it, and I've worked at a university, so I believe in clinical trials.
You believe
and
in the
being able to
science.
participate.
I'm going to think about you every time somebody says something to me, and I need to sit up forward and posture myself towards somebody to say, I could do this. Don't tell me I'm weak, right?
That's right,
Okay.
absolutely.
You will never say that again
Never.
to somebody.
Best way to get you to do something.
Exactly.
All right, Dr. McGurk, let's let you wrap us up. What's the takeaway today?
Well, I think the takeaway is it's an extraordinarily hopeful time for patients with a broad array of cancers. The progress that's being made today is absolutely stunning. And that's not just in stem cell transplantation, but our understanding of the immune system and its application to a broad array of cancers: breast cancer, colon cancer, lung cancer. Manipulating the immune system has taken us a long way, but in no area has it been as successful to date as it has been in the context of blood cancers. So that's a very promising time. But one of the other important points about what we discussed earlier in terms of the majority of patients who might need to optimize their chance of being cured, a stem cell transplant, not having a matched donor. that's even worse for underrepresented ethnic and racial populations. And so for Ms. Holzbeierlein, the chance of finding a match in the worldwide registry, 75%. If she were Hispanic, it would be about 49%. If she were African American, it would be 29%. And so strategies through the work of clinical trials, like haploidentical or mismatched transplants, have greatly improved access for underrepresented populations, because now you can cross these mismatched barriers and have these transplants be successful. It greatly increases access for underrepresented ethnic and racial populations. And so when we look at our clinical trials, we are accruing a very significant proportion of underrepresented populations on those clinical trials. And in our own experience in our center, we see many more patients coming for these therapies now that simply didn't have access. And what does that mean? That they would succumb to their disease if they weren't able to access these therapies.
And you're not okay with that?
Critically important, definitely not okay with that.
So you got 50% more to go. You're going to stick around a long time then, right?
I'm God willing.
Yes, you are. Okay. Folks listening at home, though, all they have to do is go to bethematch.org, right?
That's
and they can
right.
do the swab.
That's exactly right.
So it's simple. It's you swab it, mail it back, and you can be part of the registry.
That's right. It's not even a blood draw.
Yep. Easy. Thank you so much. Thanks to all of our panel. Thanks to our viewers. We'll see you back here tomorrow.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.